Good afternoon, everyone, and thank you for joining the next episode in our ongoing webinar series, Decoding Data and Digital Health. This is the second one for 2025, and this one is looking at telemedicine and strengthening telemedicine and how best practices and what we need to think about in terms of implementing this. Data has shown that telemedicine implementation has increased, especially over the past few years, and highlighted and exacerbated and driven by the COVID-19 pandemic. And quite a lot of it, while being technologically driven, there are many other underlying factors that we have to think of. So in many cases, the implementation is not only about the technology, that is the infrastructure and the software, so to speak, but is also about doing this in a very sustainable manner and ensuring that the enabling factors, the underlying enabling factors for success and long-term implementation, we need to ensure that those are in place. And it's not just about buying software and buying hardware and putting it in place. We need to ensure all the other aspects are in place, especially if we want to have established, dedicated, and sustainable telemedicine systems in place. Key aspects such as governance, sustainable financing, quality and safety, and of course, alignment with care pathways and ensuring at the end of it all that there's equitable access. All of this is crucial. So this webinar will seek to touch on these underlying important factors, not so much as, oh, you guys need to buy computers, you need to put internet access in place, but more on the very underlying foundational aspects of this. So a brief overview of the agenda. We'll start with a presentation on telemedicine across the WHO European region and OECD member states. And then we'll go into the panelist discussion, and then we'll take a few answer a few questions. So let me introduce the panelists. We have, first of all, Rishabh Kilara, who is a health economist and a policy analyst at OECD, and he's doing leading work on digital health within the OECD. And he will be doing that presentation for us shortly. Our panelists are Ana Luisa Naves, who is a clinical senior lecturer in digital health and a director of the Global Digital Health Unit, which is a research hub for innovation and entrepreneurship in healthcare. We also have Assistant Professor Damir Vazanik, who is a Deputy Director of the Croatian Institute of Emergency Medicine, Assistant Professor at the Catholic University of Croatia. And he also works as an external associate at the University of Applied Health Sciences in Zagreb. And he works a lot in leading telemedicine in Croatia. Also joining us and representing the Ministry of Health of France, we have Camille Oms, who is part of the French General Care Organization and Directorate, and then she's in charge of telemedicine development with a particular focus on remote patient monitoring and organizational strategies. And we also have Ilham Chikroun, who is a pharmacist working in a Social Security Directorate of the Ministry of Health France, and responsible for areas of reimbursement to health products, including telemonitoring and digital therapies. So thank you all for joining us and being a part of this, and looking forward to a very fruitful discussion that we hope would be very informative for attendees. Rishabh, without further ado, over to you to share the presentation and have a few discussions introducing the areas that we're talking of.
Sounds great. Thank you, Ryan. I have to do the usual check to make sure everyone can see my screen.
Yes, we can.
Yes. Okay, perfect. Good. Well, hello, everyone. My name is Rishabh Kilara, as Ryan mentioned, and I'm a health economist at the OECD here in Paris. We've led numerous analyses on telemedicine post-pandemic and during the pandemic, which is kind of the interesting question I think we're posing our panelists today. And I couldn't help myself, but it's so exciting to have a virtual discussion on a virtual care method. But anyways, I won't get too nerdy too early. So let's maybe start with the question that motivated our recent work on telemedicine as well as the WHO. During the pandemic, telemedicine was rapidly increased the usage across member countries, and it was really deployed as a substitute for in-person care during a time when in-person care was not always feasible. And it was deployed as such, and it was also governed as a substitute. It was financed as a substitute and implemented as a substitute for in-person care. I think the big question for us now, post-pandemic, in an era where telemedicine is sitting alongside routine, normal in-person care pathways, is are those pandemic-era implementations of telemedicine sustainable and realistic for telemedicine beyond the pandemic and how it's being used in our current methods? So there was a analysis done during the pandemic from the OECD, which looked at three major questions that countries were having for telemedicine use beyond the pandemic and kind of what happens after this. And there was three main areas. One was on data collection, understanding who is using telemedicine, where, when, why, and what is happening to patients after they use telemedicine. The second is financing. Are our current payment models actually fit for purpose and flexible enough to account for the different ways we use telemedicine and the different models of usage? And then third is looking at integrated care of telemedicine models and ensuring that there is a seamless pathway between remote and in-person care for patient pathways across both primary and secondary care. So these three themes were kind of what informed our post-pandemic work on what telemedicine looks like after the pandemic. Now, the WHO in Europe has done a lot of analysis on telemedicine usage kind of in these key couple of years after the pandemic, and it's found broadly what we can all agree with. The vast majority of countries have used telemedicine and embedded telehealth into their digital health strategies. And as you can see, this is across a very diverse range of telemedicine models: teleradiology, teledermatology, telepsychiatry, telemonitoring. There's a wide range of modes in which telemedicine and telehealth can be used and deployed, which also points to the complexity of actual using telemedicine, but we can get to that a bit later. This is mirrored in OECD analysis, and I want to point to one caveat. In a recent Paris survey, which is one of the largest patient-reported indicator surveys, this is on patients over 45 years with chronic conditions. The vast majority have providers that offer teleconsultation, and they view it as trustworthy as face-to-face consultations, but only 7% of a patient's last consultation was held virtually, which to me indicates the gap that is kind of the purpose of this discussion today, which is we know telemedicine is being used very widely. It was being used widely during the pandemic, and it's still being used widely and increasing after the pandemic. But there are still gaps that remain. There are still gaps in how patients who, we could argue are some of the most patients that need more access to care, patients with chronic conditions, are not able to capitalize on the use of telemedicine services or telehealth services. Perhaps they view them as trustworthy, but actually getting patients onto a pathway where telemedicine and telemonitoring can be used seamlessly has been more difficult than we have imagined. So this question of how do we understand this increasing use of telemedicine and ensure that it can be integrated into patient pathways across health systems is one of the key post-pandemic era questions for telemedicine implementation. So, don't want to get too ahead of myself. So, and I apologize, I speak very fast. So if you have any questions or concerns, do let me know. The OECD did an analysis just last year where we interviewed about 30 experts of telemedicine across different OECD countries. And we brought back those three questions that we had post-pandemic: the data collection, the financing, and the integration of telemedicine into different care models. And we were able to see a number of different exemplar models of telemedicine implementation, two of which you'll hear today from Croatia and France. But there's also a number of different models across federated systems like Canada and Australia, fully in-house built systems like in Turkey with the eNaviz platform, and numerous different models, triage models, and what's much. But I think through these discussions, we learned maybe some important lessons for what telemedicine looks like in this post-pandemic era. Now, there's a lot of text on the slide, so I don't want you have to squint your eyes. But what I can say about this is we identified 8 leading practices from our analysis. And if I had to group them into 2 key themes, the first theme is capacity for evaluation. And this is granular data on activity of patients using telemedicine services, outcomes ideally, as well as the financing. So granular billing codes, and consistent billing practices and actual granular codes of how we're coding telemedicine across the health system usage. That's half the picture. The other half of this evaluation recommendation is actually using that information into embedded evaluation processes. So this is not just a commissioned survey every couple of years. This is regular granular data on who is using telemedicine services, how much does that cost, and what are the different modalities of telemedicine being used, what are the different demographics of patients using telemedicine, and using that information into regular evaluation practices. If I can give an example, let's talk about video consultations versus telephone consultations, right? They were used as substitutes during the pandemic, but as we emerge from the pandemic, we need to understand how patients were using those different modalities in different ways, and then use that information to then maybe reform and kind of create a flexible payment model based on the modality. Without that information, we can't really ensure that telemedicine can be used sustainably from then on. And having this evaluation process is one of the key enablers that we saw in ensuring that telemedicine was used in a way that was responsible, safety. It targeted groups that were not able to access care, and ensure that it was financially sustainable for the long term. The second area of recommendations is on inclusive governance. And so this covers 2 big areas, obviously governance, and this is really, we called it embedded stakeholder engagement. Poland, for example, has roundtables for every telehealth initiative and policy evaluation, but having, I think, most importantly, patients and providers at the table understanding when changes to telehealth care models are being implemented and having their input on the actual usage is one of the most important recommendations that I think we saw. Procurement obviously is an important one. I don't want to get too technical now, but having just standardized security and technical requirements for procurement is a really important enabler. And then finally, which I know we'll talk about a lot more later on, but I think supporting integrated care models is a difficult question, but something, if you can get it right, is really exciting. And this is promoting the discovery, the scaling, and then the implementation of new telemedicine care models. I don't want to spoil the surprise, but France has a really exciting example of how they can do this by having a collective framework to look at evidence from different pilot models for telemedicine. And this is a really interesting way to identify new telemedicine care models and ensure that they are meeting the safety, the quality, and outcomes assessments that we like, and ensure that they can be scaled nationally. This is one of the ways in which I think telemedicine can be seamlessly integrated into new patient pathways and used more broadly across the system. Okay, I know that was a lot of information, so I will do quite the opposite. This chart is our assessment of OECD member countries across these 8 leading practices. And the actual values of each country are not so important here. What's important is that every country has room for improvement. But this is where we are, I think, post-pandemic. We are in this era of reassessing which telemedicine models are actually fit for purpose with current post-pandemic patient care models, right? We're looking at the data availability. We're looking at the incentives and the costs for different care models. We're looking at how to standardize procurement, the basic technical requirements. We're looking at how to scale up pilot models from just pilot models. All these things are kind of in flux, but I think having this flexible and standard, this kind of basic governance to achieve those key capabilities is the next stage of telemedicine after the pandemic. So this, I think, is kind of where the joint webinar really shines, because this is where OECD analysis kind of links directly into the implementation that the WHO Europe has. The most important thing is that our analysis and the WHO recommendations are completely aligned. And I think they've done a good job of mapping our kind of mid to low level technical policy recommendations to these large key themes on implementation of telemedicine. So these are mapped across monitoring, evaluation, governance, sustainability, infrastructure, workforce, application layer, which I'll go into a bit more detail later. So WHO Europe has developed this support tool to strengthen telemedicine, which assesses 5 core implementation areas across 7 horizontal cross-cutting domains. It kind of creates this matrix of implementation across the key stakeholder levels, as well as the actual policy vertical delivery areas. And there's an assessment to really map out where countries are in their implementation pathway for telemedicine. So this is a really important kind of next step, because as we are reevaluating telemedicine models post-pandemic, this is kind of mapping out where we are to get to those recommended areas that the WHO and OECD both share. And I think through this exercise, it's an exciting way to engage other stakeholders. You have an evidence-based approach, and then it kind of maps up the priorities for telemedicine to national digital health strategies, which are hopefully already pre-existing. But this is, like I said, taking some OECD analysis and putting it into that long-term WHO implementation guidance, which is really helping countries who I think are coming out of the pandemic with questions about telemedicine and taking it into the future of how we can actually put those recommendations into place. So I don't want to take too much time from the panelists, so I will kind of leave it there, and maybe we can come back with questions at the end. But the main thing that I want to stress is we are in this area where we are understanding how does telemedicine fit into healthcare today. It's not the same picture as it was during the pandemic. The telemedicine is a supplement and a substitute. And how can we understand how its split usage is best placed across our existing patient care models? How can we scale new solutions? How can we ensure that it's being used equitably? And what frameworks, such as data granularity and evaluation, can be used to regularly assess that it's being used properly? Can we have standardized procurement and ensure that these meet our standards? So I think it's an exciting area, and Ryan and I are very excited to kind of speak to the panelists and hear about some countries and research that Anna has done on kind of where people are doing things correctly and maybe things that we are missing in our assessment of what telemedicine looks like post-pandemic. So I will leave it at that, and I can hand it over back to Ryan. Thank you all for joining and for listening to my very fast presentation.
Thank you so much, Rishabh. Great. So Rishabh, I have one quick question. I'm going to give you 1 minute to answer, and then we go on to the panelists.
Okay.
So I have a question from the audience, and it's asking, considering the granular results, measurement, financing, governance, and integration, did the study investigate the barriers and enablers for each element in general or per country?
Well, that's a good question. Some of the barriers were structural, which means it depends on the health system of the actual country that was being assessed. So, for example, well, the short answer is yes, but in general, but also I think it depends on the country context. The biggest example is federated countries versus a national health system-based country. So federated countries would have difficulty in data granularity and comprehensive use of that data for evaluation, but with use of interoperable data standards and perhaps a national insurance with national reimbursement codes, and having standardized data, having data standards that allows data to be comparable and at a national level, you get around those issues, right? So yes, some barriers were based on the country context, but there are kind of general considerations of a lot of these kind of issues and concerns. I think as digital health becomes more embedded and interoperable information becomes more commonplace, we can hope that those structural barriers start to erode. That would be my 2 cents.
Thank you so much. So without further ado, let me get straight into having our panelists have some discussions based on what their expertise and areas of work are, and to build on what was presented on by Richard. So I'm going to start with Ana Luisa. So Ana Luisa, we're going to look at starting looking at it from a governance perspective, which is very important, ensuring that there's governance underlying telehealth within the larger context of digital health. So what do you think are the main challenges for policymakers when implementing telemedicine with patients and providers, and how can we better engage them?
Hi, Ryan. Thank you so much for the question. I think implementation is always the most important part of health services research. We all have this excitement about innovation. Some of these theoretical concepts work really well in practice, and sometimes they work really well in local settings. But when we try to scale up, the challenges are much bigger. So on top of that, and as Rishabh also mentioned, we are operating in a very particular space now. We are transitioning from a world in which we use telemedicine as part of an emergency response, and we are transitioning to a world in which is actually part of our routine care and is being regulated by a quite fast evolving landscape. So I think that transition is really important because we need to consider that the wider implementation of telemedicine has happened during the pandemic, where a lot of the regulations were flexed and waived, and that gave us a new space to operate that now we need to retune a little bit. So thinking about specific challenges, one of the main ones is workflow integration. We know this works for certain patients, this works for certain disease areas, but in order for it to be adopted in a sustainable way, we need to make sure that this is fully embedded in current processes, current workflows. Physicians and systems are already quite overloaded with a lot of different clinical tasks, operational tasks, management tasks. So technology should be there as a way to help them to improve access to care, to support patients, rather than being an additional burden. So that's a critical area. How can we make actually technology to integrate, to be a seamless piece of the puzzle that actually doesn't create a new click, a new platform, a new burden. So that's one of the most important parts. How do we integrate technology? How do we make sure that data are interoperable, that they can be combined, that they can be shared between different platforms? So the other aspect is about, and we have discussed that, and that would be a wider discussion about how do we make sure that is equitable and accessible. A lot of work for us to do there, of course, engaging with patients and the public, but also engaging with professionals. And I think we need a change in this conversation. Of course, we need to change to support patients, but also our workforce is not necessarily trained to operate in the world that's becoming more and more digital. So this needs to be a quite wide effort, maybe a system thinking approach in which how we think, how to support, how to train the whole population, the whole users involved, including physicians and patients as well. And the third aspect on implementation, I think that's something that's really close to my heart, is how do we make sure that we are implementing solutions that have proved their value? And with telemedicine, we all rushed into adoption. We didn't really have a choice. We keep using many of these solutions, and that includes virtual consultations, but also mobile tools for self-management. And the evidence backing up its impact on quality and safety of care is still relatively limited. So we do need some support, and that will involve partnerships between healthcare organizations, policymakers, academic organizations, and patients to understand which telemedicine solutions have proved their value. How do they impact quality of care? How do they impact safety? How do they impact patient experience? And based on that evidence, use the information to scale up the solutions that actually help people, and maybe reconsider solutions that maybe won't have a positive impact on quality and safety of care. So I would say these are the three main areas that I would highlight here. So making sure that technology and telemedicine is embedded in processes of care, making sure that's accessible and equitable, and that talks about training, but a much wider effort as a community, and also making sure that we are operating in an evidence-based place, because ultimately it's our patients and it's our public safety that's at risk. So we need to be very careful on how we protect them and how we protect ourselves as systems, making sure that we are providing the best care possible. And ultimately integration is, and ultimately technology and telemedicine in this case is just another piece of the jigsaw. It might be exciting, but it needs to fit providers' needs to fit patients' needs to fit the processes of care, because otherwise we'll end up as a shelf solution, as many others have been in the past.
Great. Thank you so much. And very well put into those three very important underlying aspects. So next I will call on Damir from Croatia, and to have a more idea from a country perspective. So Damir, Croatia has a centralized telemedicine system that's administered through the Croatian Institute for Emergency Medicine. How is this structured governance model supporting the implementation and evaluation of telemedicine services? And how do you manage access to specialists and secondary care via these telemedicine services? So if you can give us a brief as to the whole governance structure behind how this operates. Thank you.
Thank you for your question. To operate as a centralized system, it must be founded on a legal basis. The legal frameworks, specifically the Healthcare Act and the Ordinance on Conditions, Organization and Methods of Telemedicine Practice, grants the Croatian Institute of Emergency Medicine authority over telemedicine activities. This authority encompasses managing the network of telemedicine centers, ensuring standardized implementation, providing technical support to users, training healthcare professionals, and overseeing the operation of telemedicine centers. For instance, if we detect that the telemedicine center has been inactive for a certain period, we can respond and investigate whether there is an issue or a change in its operational structure. If the solution is technical, our technical support service resolve it, and if other interventions are required, we can contact the appropriate competent institution in time. This management model prevents the unplanned establishment of telemedicine centers, guarantees a high standard of service quality, and facilitates effective monitoring of telemedicine service delivery. And your second question regarding how we manage assets, I would say that the legal framework also enables us to differentiate between telemedicine access center and telemedicine specialist center. Patients with referrals for specific specialist services visit a telemedicine access center established at the primary healthcare level, where trained healthcare professionals prepare them for the specialist service. The actual specialist service or interpretation of results is conducted at the remote specialist location in a telemedicine specialist center within a secondary or tertiary healthcare institution. For example, we offer specialist telecardiology and telepulmonology services for patients in health centers with their local communities, undergo preparation for specialist examinations such as ECG, spirometry, Holter ECG, or blood pressure monitoring. Specialists in distant healthcare facilities then interpret these findings. And by entering the result into the hospital information system integrated with Central Hospital Information System of Croatia, the findings are transmitted back to the family physician and also added to the patient electronic health record.
Thank you so much, Damir. And I think that gives a nice country example that meshes very well with what Ana Luisa was saying in terms of how you need to operate and the key areas you need to look at. Evidence-based. It needs to build, ensure that it's training and takes care of your health workforce, and in terms of being accessible also. Going on to France, let's hear an example from France in terms of that. So France has developed regulatory pathways for telemonitoring, and as was alluded to by Ana Luisa, we need to ensure that whatever we're doing, it needs to be integrated in what exists. So France has developed regulatory pathways for telemonitoring, integrating it into routine care. So what I would like to know is what key governance structures do you have that has facilitated this? But also, very importantly, what key challenges remain in scaling telemedicine nationwide? As Ana Luisa alluded to, scaling is a very important aspect. Over to you.
Thanks for your question. So first of all, France has implemented a strategy to accelerate digital health, demonstrating a strong political commitment to develop and to invest in this sector. About the stakeholder, I will try to be as simple as I can, but only one delegation has been created in 2019, the Digital Health Delegation, named DNS, and its role is to implement the strategy that accelerates the development of digital technology. For example, concerning telemonitoring, DNS is responsible for ensuring the security of the device and interoperability. Otherwise, I would like to highlight that the three usual institutions responsible for granting access to healthcare reimbursement have assumed these new missions. So I will summarize quickly what they do, but the first one is the National Authority for Health. Some of their missions are to assess medical device eligible for reimbursement, recommend best practice for healthcare professionals, and develop public health guidelines. A second one is the Social Security Directorate, where ILM works, and so-called name DSS. And the DSS is in charge of the financial part of the care system and of its regulation. The last institution is the General Care Organization Directorate, where I work, and we are in charge of the organization of the care offer, and our goal is to facilitate the usage of telemedicine by the HCP. So what I would like to highlight is that either for the creation of the new model or the follow-up of the implementation, everything has been done in consultation with stakeholders, so the manufacturer of the medical device, the patient, and the HCPs.
About the challenges, the biggest challenge was to build the solid foundation, a sustainable model that can support all indication and patient populations. So we needed a robust framework that can adapt to evolving needs of patients, healthcare professionals, and the new technologies. But right now we are facing new challenges, and for the manufacturers, the first one is that the startups, they often lack experience in designing clinical studies for reimbursement. So unlike traditional drug, we rarely have phase 3 controlled trials. The second challenge we are facing is interoperability issues, because there is a clear divide between the data manufacturers that are generating the health data and the agnostic system that need this data to ensure seamless integration into existing healthcare systems. Therefore, that challenge can lead to the economic impact question. Should we reimburse separately each component, or should we adopt a more bundled payment model? Today, we have a strong collaboration between stakeholders. We use this collaboration to adapt the regulation and answer this previous challenge and the next challenges. So now Kamini is going to present the other challenges.
So we spoke about the challenges for the manufacturer, but there are also challenges for the HCP. So what we have seen is that supporting change has been key, and it's still important. Telemonitoring is a new paradigm that requires healthcare professionals to adopt new way of working. invest in new organizational structures, and dedicate some time initially. So, however, once it's implemented, it becomes more efficient. Then the last challenge is also for the government. So we have two challenges. First is management and assessment. Measure activity and evaluate efficiency for patients, organization, and institution is not straightforward. So we still have questions like, does it contribute to the personalization of the treatment? Does it still lead to cost saving and improve healthcare? We don't have all the answer yet. And the second challenge is that the previous pilot we have run called ETAP was based on 5 chronic diseases. And so we have designed the current model thanks to it, but we have now to check if our current model is adaptable to a new area of care, such as surgery or acute diseases. So I just would like to finish that we have implemented our current model 2 years ago after the pilot we run. And we believe that it works since we have positive feedbacks, and we have implemented 2 new areas of care, oncology and chronic low back pain.
Great, thank you so much. So I think it's very important the aspects that you brought out in terms of the challenges, and these are things that are very important to look out for, as well. What Damir mentioned in terms of the way Croatia is doing things and how to handle them. I know some of the key challenges, as you noted, and I think that is where a lot of implementers maybe don't put enough effort into, or should put enough effort into, is in terms of ensuring that their health workforce, they are adequately trained and supported in this, because there's a whole paradigm shift, and you mentioned change. I mean, it's not only a change in how they operate, but it's a change in terms of what their skills need to be in terms of not just digital health literacy, but, using the technology, but also, you mentioned, and Damir also noted, they need to be strongly supported by legislation in terms of the governance structure, because legislation needs to be in place to enable all of this. Without the legal frameworks, you're essentially operating outside in the ambit of the law. And I know in many legislative frameworks, it caters for face-to-face, but now when you start a paradigm of dealing remotely, for example, and handling remote care, it's not quite catered for. So legislation is also a key aspect. And you started to touch on financing. So I'll actually move straight into that. And I'll have some a little more deeper dives. But before I go on to that, I have a quick question. And if you can answer quickly, Ana Luisa, you mentioned technology integration and data interoperability as challenges to telemedicine implementation. How do you envision the integration of telemedicine use into the European health data space that has started and is coming into place in the coming years? I think you're muted, Ana Luisa.
Just trying to unmute myself. That's an amazing question, and I'll try to scratch the surface. That would require a lot of time. There's several advantages and several opportunities that I would see coming together in the European health data space. So one of them would be the vision of more efficient, more effective also data linkage, and how that could improve continuity of care across different modes of delivery, face-to-face, virtual, and most importantly, continuity between different countries. And I think that's actually one of the biggest opportunities, because what we have now are populations incredibly mobile that will use different healthcare systems, that will migrate, and quite often that continuity of care from a data perspective is lost. So I would see the European health data space as a quite strong facilitator for us to achieve that continuity in data sharing across different countries. The other area in which I think could also be interesting, although the route to impact is probably less clear, is improving or streamlining regulations to perform or to deliver telemedicine across different countries. And this is an area that still requires a lot of work. So we've been facing this challenge, well, even considering working from different countries and delivering care from different countries. So we do need some clarity on what sort of telemedicine can happen across borders and how is the best way to deliver it in a safe way. And I would imagine that from a regulatory perspective, the European health data space is going to advance things on that angle as well. But that's an excellent question, and I think we'll probably need a lot of time to cover it properly, but hopefully that scratches the surface.
Thank you, Annalisa. Yes, I think when it comes to European health data space, we probably need an entire webinar or two to actually get into the intricacies of that. Thank you. So as noted, I would like to go into financing because that's also an important aspect. How do we sustainably finance telemedicine is something that has been noted in the slide that Richard was highlighting. It's a key part of what we in WHO and OECD are looking at when it comes to implementation. So I'll start with Croatia, and then I'll move on to France for you guys to go a deeper dive into some of what you started to highlight on. Croatia, you guys have a structured outcome-based financing model that is actually unique among the WHO and OECD member states. How does this financing approach improve the efficiency and sustainability of telemedicine?
Thank you for your question. Croatia has integrated telemedicine into its healthcare system not merely as a reimbursement mechanism, but as a standardized practice for delivering health services funded by the Croatian Health Insurance Fund. Our financing model defines specific diagnostic and therapeutic procedures, DTP, for various telemedicine services, enabling transparent billing and performance monitoring based on completed procedure. For telemedicine services, funds are allocated between procedures performed at the telemedicine access center and those conducted at the specialist telemedicine center, effectively distributing resources among different stakeholders into the entire process. This approach incentivizes stakeholders to incorporate organizationally facilitates and financially recognize remote medical services into their practice, which are professionally equivalent to the traditional methods of medical service delivery. Regarding the development and implementation costs of new telemedicine services, Croatia has successfully leveraged available EU funds, specifically Next Generation EU for teleradiology and teletransfusion, as well as resources from DigiReform and the World Bank to develop a new telemedicine service in emergency medicine. These investments complement EU fund projects within the regular multi-annual financial framework 2021 to 2027, through which we are acquiring medical communication equipment for EMS vehicles. This equipment is required to have functionalities that will enable future remote patient data transmission.
Thank you, Damir. I think that's a very, very interesting way that, and I think it's something that other countries can learn from in terms of, I know largely we think a lot about digital health and digital health implementation as, add on the health, and the way you're going about it, especially in terms of telemedicine and telehealth, is it's actually integrated into part of your care. It's an integrated part. As we in WHO sometimes like to say, moving on, eventually we don't want to hear about, we have healthcare and then we have digital health. Our whole goal is to have digital health integrated as part and parcel of our everyday care and care pathways. And what you mentioned is a good example of that, I think. Going back to France, in terms of what you noted, I think some of what you started to highlight earlier, for example, you have the pilot program like the ETAPES to determine sustainable payment models for telemonitoring. But what have been the biggest takeaways from these pilots and how have they shaped your long-term financial strategies?
So our pilot program called ETAP was key in shaping the current model. It lasted 5 years and it ended in 2023. During this pilot, we had 3 different kinds of fees, one for the alert treatment, one for the therapeutic support, and one for the medical device. And it was a monthly fee per patient. We implemented our current model 2 years ago, and as I told before, this new model is inspired by the experimentation, but we wanted to highlight coordination between the HCPs. And so the biggest challenge was to build a model that can cover any kind of therapeutic areas and also that can adapt to the patient severity. So indeed, the fee is predefined and can be modulated according to the patient severity, because we know that severe cases are more complex to manage and require more time and expertise from the healthcare professional. And so our new model is innovative because it combines the financing of the HCP for the telemonitoring in one hand, and on the other hand, the financing of the medical device supplied by the manufacturer.
For the MD, we didn't follow the usual path for MD reimbursement and pricing because there is no negotiations conducted device by device. There's just a fixed fee. And the fee is predefined with different level according to the impact, whether organizational or related to mortality. And the price increased from the lowest impact to the highest impact, like mortality. Last but not least, to be reimbursed, you have to prove by your data an effective use of the MD. That is the newest thing we put in, and it is a bundled reimbursement model.
Thank you so much. So I'll move on now to something, and I think is a burning thing that is coming up in the chat, and I know it's something I also wanted to ask you guys about. So one of the things that was highlighted and is coming out of the chat, and so I will do it in two parts. We're looking at how, in terms of integration, and this first question is from Ana Luisa. How can telemedicine platforms be designed to enhance continuity of care while preventing fragmentation?
Sorry, Ryan, would you mind repeating because you broke just for a sec?
Okay, so I'm looking at it from an equity perspective, and you know, having this integrated, and it's coming out of some of the questions from the audience, as well as some of the discussions with Damir in terms of having this integrated. And so it's the question for you is, how can telemedicine platforms be designed to enhance continuity of care while preventing fragmentation in your systems?
Ryan, I'm so sorry. Can you hear me now?
Yes.
Connection is, sorry, I'm going to ask you again, sorry, because it's breaking. Can you repeat just one more time?
Okay, I'll repeat one more time. Are you hearing me?
Yes, now I am.
Great. How can telemedicine platforms be designed to enhance continuity of care while preventing fragmentation?
Thank you so much. So that's a very key point, and it's also linked to what we mentioned about data continuity. So we need data between telemedicine platforms to be interoperable with ongoing systems. So systems that are mainstream, that are used in primary, secondary, social care, public and private systems. In an ideal world, they should be able to communicate that information. Because what we are seeing at the moment is really, because these platforms are not able to communicate with each other, a lot of information is lost in translation between transitions of care. And these transitions might mean transitions from primary to secondary, might mean transitions from public to private, might even mean transitions between what we would call a more traditional delivery to care and the information that's collected through apps, self-management solutions, etc. So what's happening at the moment is, because if you think about telemedicine as a broad concept, which includes government-funded, private-funded, but also all the technology that we have on our hands all the time, all of them collecting data that are really not coming together is posing risks to safety, really. Because what we're seeing is that all these moves, all these slight nuances in patients' journeys are not being compiled in the same place. So whenever a patient gets to a provider, the provider doesn't really have the full story. And that's important for direct care, for decisions that as a physician I need to make now, but it's also really important when we think about predictive analytics, because these databases ultimately are going to be used for research, and we are going to make claims and generate knowledge based on very incomplete and very fragmented information. So I see those two major risks. So one for direct patient care, because we are not getting the full story that allows you to make the right decisions for the patient sitting in front of us. And also when you think about secondary uses of this information collected through telemedicine platforms, this information is going to be incomplete. Of course, we know it's also being to be inaccurate and all the issues with big data, and ultimately can generate knowledge from a predictive analytics perspective that's not appropriate. So the efforts would be really through creating better communication strategies between different platforms, and also about creating better communication strategies between the providers and the multidisciplinary teams alongside it. Because of course it's about making technology interoperable, but it's also about making the system and the people behind it, which will be pushing technology, interoperable in that way.
Great, thank you. So this is an open question for all of you, and I think is an important one, and this is again from the audience. And this was also alluded to in the OECD paper, that there is limited scaling of telemedicine beyond pilot projects. So open question to all of you, and we can start with France and then Damir and Ana Luisa. You know, we keep thinking about we're doing this and we need to scale up. So what does that mean? How exactly do we go ahead scaling up in an effective and sustainable manner? Over.
So first, I think we have the pilot we run help us to scale up, then to scale up telemonitoring. There are some. So the regulatory pathway is really important, and as we told before, the financing part also that would help HCP to use it, and also help manufacturer to develop solution. So this is like an incentive. Then we have to train also the HCP. It's just not a tool. Telemonitoring will modify the practice of the HCP. So we really have to work on new organization. And so this innovator we had during the pilot called ETAP help us because it was a kind of ambassador of telemonitoring. And so we can they can testimony on their experiment and how to structure the healthcare team to follow the patient. So that was also an important key. And maybe I will let the other country complete my answer.
Thank you. So Damir, I'll hand over to you, considering that you have within Croatia, you have it well integrated or on the way to being well integrated into your health systems. So what would your advice be in terms of scale up?
To foster telemedicine implementation and innovation, countries should establish sustainable funding model that encourage adoption and investment in robust IT infrastructure, while also defining clear service reimbursement structures. Ongoing education of healthcare professionals and also the public is essential for building trust to ensuring effective utilization of telemedicine services. Monitoring health needs through data collection aids in tailoring services to local requirements, especially in underserved areas. By addressing these aspects, countries can enhance healthcare accessibility and outcomes while preparing the future advancements in telemedicine.
Thank you, Damir. Ana Luisa, anything to add?
Yeah, so certainly from an infrastructure perspective, financial, reimbursement, legal, regulatory perspective. So we do need, and many countries already have these high-level digital health vision, a digital health strategy that makes sure that these initiatives are not short-lived. They can go beyond the regional funding or beyond the regional pilots. So that's for sure a main infrastructure concern. I would say patient provider user engagement in general, it's a huge area or priority for scalability. Even if everything is perfectly in place, if the user is not engaged, again, it won't fly. And for me, something I think it's really important, and I really like the way the question was posed about how is the scale up accessed practically? So how do we know if the scale up has been successful? And I think that was a very delicate way to put it, because this assessment of the success of the scale up needs not only to check if the numbers are going up, if I have more people using telemedicine, I need to know who are the people using telemedicine, because we might get numbers going up, but we might be actually doing that for those that are more literate, already in better positions in society. So we might be inadvertently increasing digital inequities through that. So I really like the way the question was posed. Yes, measuring scale up is important, but how do we do it in a way that's meaningful?
Great. Thank you so much, Ana Luisa. So we're running out of time, but I have one last question, and I think it's very important. Within the ambit of digitalization and, of course, telemedicine, which is a key entry point for many places, many countries. And so this is open again to all of you before closing. So what strategies have been most effective in expanding telemedicine to underserved populations, basically ensuring that any scale up, any implementation of telemedicine is done in an equitable manner to ensure that no one is left behind? So who would like to start to take this?
So first of all, the reality can be different from what we might expect. For example, if we take teleconsultation, it's more common in urban centers than in rural areas in France. And so that's why we have developed assisted teleconsultation with nurses or pharmacists. And if we have a look on telemonitoring, we could have the idea that older people cannot use digital app, but what we see is that they use it to communicate with their grandchildren, for example. And in fact, older patients tend to be more consistent than younger ones. So as long as the patient gives its consent and receive a proper training, telemonitoring will work effectively. And therefore, telemedicine cannot replace face-to-face medicine. It's an additional device in the toolbox of the doctor, but the HCP has to check with his patient if it's appropriate or not. And in France, we monitor the adoption of telemedicines. We have 3 specific indicators to monitor. So the first one is the usage rate by the HCP. The second one is the usage rate of chronic patients and how many of them benefit from telemedicine. And the last one is a quality indicator to check the availability of telemedicine in area where the care offer is not sufficient. So we use and we follow national rate to monitor adoption. And one point is our incentives are aligned with medical needs, and it's not a volume-driven pressure. So this is important.
Thank you so much. Any final comments? Any other comments from Damir or Ana Luisa?
Yeah, I can just compliment. I'm not going to repeat what Camille said, because of course she posed it in a very nice way, supporting patients, using in a positive way, caregivers, family members, supporting the infrastructure. But I just wanted to end up in a positive note as well. So we talk a lot about the digital divide, and we know it's there, and we need to be mindful of it. But telemedicine is actually also reducing inequities in some very interesting ways. With all the relaxation that we have seen in regulations during the pandemic, countries that were not able to do telemedicine were now able to do it. And if we think, for instance, about telephone consultations, which are a very democratic type of technology, they have actually increased or facilitated access for patients living in rural areas, remote areas that didn't have that sort of access, and now they can actually see a provider or consult a provider through that means. So I've seen that in a survey that we've run in 20 countries back in 2020, people actually saying telemedicine is reducing in some cases inequities. But again, it's not a one size fits all. It will work for some patients, it won't work for the others. And that's the sort of nuance that we need to clarify to get it right.
Thank you, Ana Luisa. So unfortunately, we're out of time, and there is so much more that we can talk about on this topic, and hopefully we have another opportunity. So I'll give each of you one last moment to give any final remarks that you want to share with the audience before we close.
But maybe just to conclude, we note that create a regulatory and financial framework that ensures the quality of care while remaining flexible and encourage innovation and adoption. And in France, the pilot we have done really shaped the current model. So we have to be patient, but it works. And integrate digital tools into patient pathways is really important. And yeah, that's all. Thanks a lot.
Thank you so much. Damir?
I agreed with panelists that already said everything. I think that telemedicine is not the future, it's a present, and we need to use all these tools that we have already. This is very good for our patient, especially in countries that has patient in some remote areas on islands like we have in Croatia. So we need to improve all of this to be next to the patient with all services that we can provide him.
Thank you. Annalisa?
Yeah, I think the main thing is, I agree completely with Darmir, is the present. It's how we make our way moving forward so that it's a blended model. So we are not talking about replacing usual care by telemedicine. We are talking about understanding when can telemedicine be useful, for which patients, and try to offer it as an alternative way of care or a complement to our usual way of care. So I think that's that kind of reorganization of health systems delivery that we need to work out and try to understand what works better for individual patients, because we won't find a solution that works for everyone. So we need to have systems that allow that flexibility without closing the doors to those that need it most.
Thank you so much. So I just want to say thank you so much to our panelists for this very interesting discussion. There was so much more that we could have touched on. And as I mentioned, hopefully we can do it. And I know the audience had quite a lot of questions. We tried to highlight some of the very important ones we thought that was necessary, to ensure that its telemedicine implementation is done in a very sustainable, equitable manner, and it's financed, and so we ensure this is long-term. And as mentioned by all of you, that is actually part of your health systems, not just an add-on, not just another thing, not as something that's replacing what we're doing, but as a complement and being integrated into our health systems, which I think is a very important aspect and a message that all of you give. And thank you also to Rishabh for the information that you shared. So I want to thank the audience very much for being here. And we hope to see you again at our next session, which we hope to be in terms of health data governance. Rishabh, our speakers, thank you all for being here. And thanks to my team also.